Good morning, everyone. I'll be presenting about paradoxical worsening of intraocular inflammation in patients with syphilis. As we know, syphilis is a sexually transmitted disease. It can be present in the body as a chronic systemic infection caused by the spirochete Treponema pallidum. Ocular syphilis may present more commonly as interstitial keratitis or more commonly uveitis. Less commonly, it is also presented as cranial nerve palsies and optic neuropathy. About 4.3% of uveitis cases are diagnosed with syphilis. Syphilis is already popular as the great masquerade, and it can further perplex the ophthalmologist if the patient develops paradoxical worsening, and hence the study. So I'll be presenting a retrospective analysis of 3 patients with syphilis who presented with various forms of uveitis with or without systemic features, and how they develop paradoxical worsening and its management. The first patient is a 35-year-old female who was referred to us on post-operative day 1 post-cataract surgery. The patient's vision was counting fingers close to face. She had a hypopia on anterior uveitis, and clinical examination also revealed the presence of chancre-like lesions on the eyelids. There was also vitreous inflammation noted, but there were no fundal lesions in this case. So antechamber tap was done to rule out endophthalmitis, did not show any result on Gram-Sin culture, but PCR was positive for eubacterial genomes. Meanwhile, the VDR and TPHA came out to be positive. So she was diagnosed as a case of clinical worsening of pre-existing symptoms of syphilis and treated with antisyphilitic treatment along with systemic steroids, and showed good response. The second case was a 56-year-old female who was hypertensive and diabetic. Complaints of vision drop in the right eye since 20 days, also associated with headache. Left eye was normal, but the right eye showed hand movement, visual acuity. Intraocular pressures and anterior segment examination was normal. Fundus examination revealed dense vitritis with vitreous haze of grade 2, and a very faint retinochoroidal lesion could be seen, which was confirmed on the ultrasound. She was diagnosed as a case of posterior uveitis in the right eye. Laboratory investigations were done to rule out tuberculosis, sarcoidosis, syphilis, to rule out HIV, tuberculosis, sarcoidosis, and toxoplasmosis. And also AC-TAP was done, which was negative for TB, viral, panfungal, and toxoplasma genomes. Again, the VDRL and TPHA were positive in this patient. In view of history of headache and fundal lesions, CSF analysis was done, which was normal. She was started on treatment with procaine penicillin. However, she showed increased size of retinitis with suggestive of paradoxical worsening. Vitreous biopsy was repeated, again was negative for microorganisms and lymphoma. The syphilitic treatment was changed to IV benzathine penicillin, and systemic steroids was added. Here now she showed good response. However, the resolution occurred with lot of scarring. The third patient was a 34-year-old male patient, decreased vision in the right eye since 1 week and left eye, right eye since 1 year and left eye 1 week. She had a panuveitis with neovascular glaucoma in the right eye and anterior uveitis in the left eye. Fundus examination showed preretinal exudates suggestive of clinically syphilis, and it was confirmed on lab investigations with VDRL and TPHA both came positive. We ruled out an alternate diagnosis and treated with procaine penicillin and steroids along with anti-glaucoma medications. Initially, there was good response to treatment with reducing vitritis and exudates. However, after 1 month, the vision had dropped and there was increased diffuse vitritis and preretinal exudates suggestive of paradoxical worsening. We added doxycycline, which is a second-line drug, along with systemic steroids, and there was good response to treatment. And finally, it resolved with a chorioretinal atrophic patch and later developed posterior subcapsular cataract. So therapeutic paradox is known in syphilis, and this can result in extensive scar formation. After ruling out an alternate diagnosis, drug resistance and poor compliance, we can diagnose as paradoxical worsening and treat them with steroids, and it will show good response.
These patients' exposure is there?
No, sir, there was no history of exposure, and only the first patient had a systemic lesion, a skin lesion. Otherwise, they did not have any history of exposure, no prior treatment with antisyphilitic treatment as well.
You screened the families?
Yes, sir, we did check for the spouse and other family members.
Regarding your first case, if you could just make it clear, this patient had this hypopyon on the first post-op day after cataract surgery.
Yes, the first patient was operated elsewhere and referred to our center because of counting finger vision on the first day. And when we we actually check for syphilis on as a part of our routine examination as well, and at that time we
So
got
how was this paradoxical worsening? The patient was already on treatment?
yes.